Thank you for inviting us to do this wonderful talk. I think it's really relevant and really important. It's definitely something that affects my everyday career. So first, we're going to dive into some questions. I'm going to start off with what policies are in place to prevent ACEs in the district? And I'll hand that over to Dr. Jackson.
Sure. So, when I hear the word policies, I think we naturally tend to think about like legislative policy, but I think it's kind of multi-level policy. There is that kind of legal or government component to it, but there may be policies and practices within institutions or communities or organizations that also kind of weigh into that. And so kind of my response to this question is with all of those things in mind and not solely on the legislative side. And so when we think about systems and policies and programs that can contribute to the prevention of adversity in childhood, they are those things that uplift safe, stable, and nurturing relationships and environments where children live, play, and learn. And as a result or a positive consequence of those things, they can yield positive childhood experiences to prevent ACEs and kind of mitigate the effects of ACEs when and if they've occurred. And so I'll give a few examples of things that I know, and I don't claim to know every single thing in all of the District of Columbia, but I will share some of those things. And so there are a couple of programs. One is called the Period of Purple Crying, which is a prevention initiative, I should say, to prevent abusive head trauma. And it really is an educational initiative for new parents. And some hospitals have incorporated this into kind of the discharge planning for new parents from hospitals. There's the Stewards of Children program, which is a primary sexual abuse prevention initiative developed by an organization called Darkness to Light that is accessible to really anyone in our community. I know we have facilitators from our team here at Children's National Hospital. The program was brought to the district by Safe Shores, the DC Children's Advocacy Center, and so they introduced this program to us. And so they also facilitate delivery of that program. And, I mention these because while they are programs or initiatives that focus on primary prevention, there are opportunities for healthcare institutions to implement them as policy recommendations for kind of required training or implementation in your workplace. Kind of on a larger level, kind of universal pre-K, home health visitation are all policies that we know kind of promote those safe, stable, and nurturing relationships that can prevent ACEs. And so, institutionally, things that come to mind on a policy level, you may have a policy in your workplace about chaperones for sensitive exams. So, those are some examples. Screening for kind of the policy efforts to screen for family violence universally might be another policy that you might see in your workplace. At the legislative level in the District of Columbia, I can't say that there are a whole bunch of legislative policies specific to the prevention of adverse childhood experiences, but I would highlight one that I'm familiar with, and you and Claire may be familiar with others, the School Safety Omnibus Amendment Act of 2018, which is a legislation in DC that requires schools to take steps to prevent and address student sexual abuse by school staff and student-on-student acts of sexual harassment and sexual assault and dating violence. So that is one like very specific legislative example. And often when we think of ACEs, we think of early childhood, but it really is across the breadth of childhood. And so that is just one specific example, but you all may have others.
That's really, thank you for sharing that, because when I think policies, I do think on the legislative level, but we have policies in everyday things, right? And like, and how we even how even community organizations, not even such like hospital settings, have policies on how we address things. And so even if we might not be aware of the full breadth of things that are offered in the district, I'm sure there's many things that other organizations outside of children's or even really formal organizations are actually doing things to address some of these childhood adverse events. Claire, I'm going to turn this over to you. Do you have any additional insights in this question?
Sure. And I'm going to pick up on these macroeconomic or much broader policies, Dr. Jackson, that you identified, because I think they're really important and can't be underemphasized. And we often don't think of some of these policies as designed to address adverse childhood experiences. And in fact, maybe they're not designed in that way, but we're finding in the research that they're having that effect. You mentioned the universal pre-K in the District of Columbia. There's a fair amount of evidence across a number of studies showing us that childcare is a pretty potent preventer of child abuse and neglect. We think that there are probably a number of mechanistic pathways by which that's occurring. Families have more cognitive bandwidth if they're not trying to find childcare. They're able to earn more money because they're in the marketplace. They're able to go to work and have sustained, stable childcare. They're not leaving children with inappropriate caretakers when they are pressed for childcare. So we know that the more states are spending on childcare in particular, we do see reductions in child abuse and neglect. You mentioned a program specifically designed to reduce abusive head trauma in children, the Purple Crying Initiative. And we also see a few studies at the macroeconomic level that show us some associations or correlations with reductions in abusive head trauma as well. You might be surprised to learn that the earned income tax credit, when it's refundable, averaging only about $400 a year, we see a reduction in abusive head trauma for kids under the age of 2. We also see out of the paid family leave study that looked at California's use of 12 weeks of paid family leave, we also see their reduction of abusive head trauma. We have a brand new study showing that in the 4 weeks after the child tax credit funding came out during the coronavirus pandemic, that we see some reductions in emergency room visits for physical abuse in particular. So there really are sort of this constellation of policies that I can say until about 3 or 4 years ago, I never concerned myself with as a social worker who was really focused on child abuse and neglect. And I think if anything, a message that I'd bring today is that there's great value in pushing in and leaning into some of these more macroeconomic policies because we see an effect. And I'll just name kind of in a laundry list of where we have some studies showing an effect. We see increases in the minimum wage, reducing child abuse and neglect, steady employment with paid family leave and unemployment benefits. And we see in that space, the tax credits, EITC, we have a pretty large and growing evidence base there, the child tax credit, concrete supports, just having health care and continuity of benefits. We see associated reductions in child abuse and neglect. And childcare, I've mentioned housing, supportive housing, stable housing, and overall benefits. The more flexible and more generous, we see benefits like SNAP, the Supplemental Nutritional Assistance Program, and WIC, Women, Infants, and Children. We see reductions. So I think there are a number of policies at the macroeconomic and public benefit platform that really should animate our attention and should be something that we concern ourselves with when we think about how to create context in which safe, supportive, and nurturing relationships can occur.
Yeah, no, I think that's really important because oftentimes we have to spend money to like save money, if that makes sense. And I actually was looking at some studies recently to talk to my psychiatry colleagues, and the CDC actually says like if we could save potentially $124 billion if we actually address a year, not just nationally, a year for that. And for every $1 spent, we save $7 annually to address these. So it's very important to look at it that way. And that might be how we can convince people to actually spend money in this realm.
I could not agree with you more. There's one study showing, and I'm just making sure I have this right, the annualized economic burden of lifetime costs is about $2 trillion. That now we're starting to talk about a percentage of GDP at that level of funding. And if we were to unlock that GDP, along with the human capital potential that is not available to us because of adversity in early childhood, we would more than pay for the policies that we're all describing today, and decrease human suffering exponentially, not just in childhood for the events that are occurring, the adversities in childhood, but over the entire life course.
Absolutely. And unfortunately, sometimes we can't just talk about the suffering. We have to find what's going to appeal to lawmakers and all these other people who are investing in it, to why it's important, not just, and besides just the emotional story that kind of takes place with it. Absolutely.
Yeah. Disease burden would be reduced enormously.
Absolutely. And I think we have to kind of all change our mindset to being more focused on prevention than intervention. Not that we ignore intervention, because we still have to respond in the moment. But, you know, it's when we think about even just healthcare, independent of adversity, we are in a very reactionary model, and we look for immediate outcomes and short-term outcomes, and that's what gets funded, because you can see on the short turnaround time what the trend is or the outcomes are. But these are much more longitudinal, and we're in a microwave generation where everything we want immediately, and that's not really going to yield us the true answers that the research continues to show us. And so we really have to shift not only our mindset, but the mindset of those in positions of power and control, so that they understand the true value of the going upstream.
Yeah, I agree. And in fact, I speaking personally, I've had that mind shift change. I'm trained as a clinician, and my orientation had always been at the individual or child level. And I think our policy framework, even as it stands today, even with the macroeconomic policies that Dr. Jackson and I are talking to you about, tends to be oriented in a medical model, that there is something to fix that is wrong with a person or with a child. And that model doesn't always allow us to think in the much broader context, that the context is as much a target of intervention as the person sitting in our office, or whatever it is that they are bringing to us that could benefit from some shift or change or treatment. Our macroeconomic policy context really is as much of interest, or should and could be, as a more micro individual perspective.
I almost hear you saying we have to address the system, not just the individual problem, because that the problem actually is the system, and we're only going to, if we don't address that, we're only going to be addressing individual problems and never really making headway into the real issue.
Exactly.
Well, we kind of breached a little bit on intervention, and so I guess I'm going to shift focus a little in that direction. So for patients who've already experienced ACEs, what policies can support patients, help them heal from the trauma and mitigate the impact? And we're, even though ACEs generally focus on the pediatric population, well, we're really seeing a lot longitudinal impact even on the adult population. So I'm wondering, you don't necessarily have to focus on pediatrics, we can also focus on adults in this question as well. And so I'll give this first to Dr. Jackson.
Sure. Well, I think, as healthcare professionals, we have a responsibility to promote resilience and the things that generate resilience in our patients and our families. And that really does require a more intergenerational look at our patients. As a pediatrician, outside of the newborn period, we don't really think about our patients as a mother-baby unit, so to speak. But the truth is that, folk are functioning as a mother-baby unit for a long time, or a father-baby unit for a long time. And so, the experiences of those parents certainly provide a context and a milieu, if you will, for that child. And so to only address the needs or the experiences of our pediatric patient and ignore those experiences that may be influencing some things on the part of the parent or caregiver is really a disservice to supporting and uplifting the whole family to promote resilience. And so, there are certainly things that we can do in our individual encounters with patients and families across the lifespan. And, some of what we talked about in the prior podcast was, as if anyone watched it, you'll know I'm not necessarily a proponent of ACE screening in actuality, but having those ACE conversations is important to make sure that folk, one, feel supported, have an opportunity to get some psychoeducation about, how their experiences might be showing up for them in their health and their well-being, even long after those experiences have occurred. And then, what is available, kind of tapping into what is available in their kind of purview to help them kind of bounce back that resiliency factor, and even to highlight what they already are doing. And I think we really have to acknowledge, I too grew up in a very deficit-based way of thinking in healthcare of, this is your problem list, these are your problems, and this is what we're going to do to address them. And it's of course all important for us to do, but boy, you could leave the doctor's office feeling more depressed than when you arrived if that's where we leave it. And so, I find myself increasingly asking parents, I hear you've been, I can appreciate you've been through a lot. How are you able to do all of this and still show up, to make people recognize that they are not a complete failure. And to tap into those things and even highlight for them those things that are helping them to succeed despite their circumstances. And I think that's one of the ways in which we can promote resilience kind of at the direct clinical engagement level. I think, more broadly, that means that we have to be and work in systems that are trauma informed, from the front desk to the back room, back offices, and everywhere in between, trauma informed in the way that we deliver care in the healthcare setting. Trauma informed in the way in which we interact with each other, because trauma is common and the likelihood is that we have colleagues who are also affected. And, you know, I think some of this is kind of thrust upon us. At the regulatory level, there are policies that already exist. You know, Joint Commission requires certain screening for safety around domestic violence and things like that. But how we do it is not quite as prescriptive from the Joint Commission. You know, it's just that we do it. And that's really where becoming trauma informed is so important. And that includes understanding from those with lived experience, you know, how should we approach this? What's the best way to approach this? And to do it consistently, which means that, and when I say consistently, I also mean equitably, that we don't pick and choose which families, you know, we ask these questions of, or even change the way in which we ask the question. So, okay, yes, we have universal screening for domestic violence, but for this group of families, I'm going to ask the question this way. You know, I just have to ask this question. You know, we're required to do this for everyone. So I just wanted to know, do you feel safe at home? Okay, well, you've really turned that rich woman off by phrasing that question that way. So even the way, you know, we have to be informed about not just the fact that we must or should do something, but how we actually deliver and engage in those kinds of conversations, so that any and everyone who is experiencing an adversity feels that you're a safe space to share information about what is happening or what has happened in their lives. And we have to acknowledge that that also means that people may not be ready to talk about it, interested in accepting the help that you know, in your best of intentions want to offer. We have to meet people where they are. And so, you know, I think on the intervention side, you know, those are the ways in which, you know, operationalizing policy is very different than the policy itself. And that is where kind of how we do it makes all the difference. It's not just checking off a box. It is so much is embedded in the delivery of that. You know, the kind of legislative interventions, if you will, that exist in the District of Columbia, I would say include the multidisciplinary team for child abuse, which is a public-private partnership between government agencies and nonprofit agencies that respond to allegations of abuse and neglect. The Sexual Assault Victim Amendment Act in the District of Columbia is yet another legislative piece that kind of delineates how we should be responding to survivors of sexual assault, and the systems and organizations that respond, and the way in which we work together to be trauma responsive in that. But, you know, again, I think the point is it doesn't begin and end with policy. I think there is that other element of kind of the interpersonal component of operationalizing a policy, which is a much kind of larger undertaking.
Yeah, I mean, I when you're hearing you talk, I'm just thinking all these things that I do here in the emergency department in psychiatry, and I'm just like, oh yeah, I say things wrong all the time, and like I get immediately corrected by someone to kind of let me know, oops, that wasn't. But it's also good feedback for me, and then I don't just like sit there and be like, okay, you know, and I do apologize. I'm not saying that, but I also internalize and say, okay, next time I have this, how should I phrase this, right? And I work with the medical students to kind of do the same thing. Like, how do I change what I said, how I said it, and what about the way I said it with this particular person made it offensive or like to them? And is it or is it their things, right? Is it something because they're not ready to discuss, and so like they think I'm antagonizing them. And so like, maybe I need to, or maybe it's a warning sign that I need to push a little further because I didn't say it wrong. Because I already have all this other background stuff that's telling me, no, this is something I need to address because something is hidden in there that I need to address at this moment. Sometimes not, but kind of figuring out what that might be. I think that's really important. And I think your other comment about having trauma-informed care is really important. Having people at the helm of your organization that are willing to address that. I mean, in the emergency department, luckily our nursing head is like, that's her jam. That's what she wants to do. She wants to create trauma-informed care everywhere. And I sometimes think that's my jam, but I'm not sure it really fully is. It's part of my jam, I guess. And so so I can definitely see having someone in leadership who actually is role modeling it for you and trying to help correct it can be a huge impact on how it's actually delivered in practice as well. One of the things I have to think about on a daily basis is when I have an aggressive patient, do I let my staff take care of it, or do I have to call in our security that look like police? And is that going to like reintroduce trauma and generational trauma and all these other things? And really thinking about when do I make that step? When do I make that leap? Because we need more manpower, and how much am I going to put this trauma onto which type of staff I have, right? Because even intervening in that way is very traumatic for our staff members too, because like you said, they're experiencing trauma as well. And so we don't know what people are bringing into the door as employers or even our patients. And so I think we have to address it as a whole system and not just be geared towards our patients, but rather to like the system as a whole. Like, how are we addressing this as a healthcare system to that, and not just, like I said, not just patients, but employees as well.
I completely agree. And I also sort of had an evolving understanding about trauma-informed care, having tried to be a student of it for, more than a decade at this point. And like all of us, continuing to learn and understand trauma and the effects of trauma. And Dr. Jackson, I think you said one thing that I think is really important, which is about meeting people where they are. And part of my evolving understanding, based on just listening to people with lived experience talk about their engagement with child welfare, or what would have been helpful to avoid child protective services related to early adverse childhood experiences, the 5 that relate to child abuse and neglect, and many of the studies that I was pointing to earlier, which is that sometimes meeting people where they are around their trauma is about helping people meet their basic needs. And that we sometimes pass by that, like we jump 4 chapters into the book. Right. Okay. So yes, right. We're jumping into the arc of someone's life when they are in crisis. And that's like chapter 4, or sometimes even chapter 14. And that by talking to people about their basic needs and how to help get those basic needs met are sort of fundamental to everything else. And in fact, I'm increasingly convinced that I'm not sure which is causal in terms of, right? Like when people's basic needs are being met and they've got mental health symptoms, I'm not sure that it's something else. Like there's a big contributor in terms of basic needs to mental health symptoms. We see that in anxiety symptoms, we see that in depressive symptoms, right? So the extent to which we're curious about whether or not families are able to meet their basic and fundamental needs when we're engaging with them, I think can be incredibly powerful as one way to be trauma informed. Because we're curious about what their day-to-day life is about and like, understanding their cognitive load, because it takes a tremendous amount of cognitive effort to meet basic needs when you don't have the resources to do so. And the extent to which, and the research is really bearing this out at this moment, where there are economic or income shocks in the lives of families. And we're getting actually much better at looking at predictors of involvement with child welfare, which I think probably have some extension to adverse childhood experiences more broadly. Using a food pantry, inability to pay for a medical bill for a sick family member, a drop in income that's unexpected, or there's no buffer from which to recover from that. The having your utilities turned off. So just understanding and being curious and including that as part of our assessment, and then having navigation or social work within the hospital to be able to connect families to the resources that better meet their basic and fundamental needs. We actually did a study a few years ago on mitigating toxic stress on the primary care platform, and found that when families were asked about their basic and fundamental needs, and then they were connected to community resources, they began to use the emergency room far less than they had previously. So I think it's all interrelated in ways that we are evolving to understand. And so when we think, when you're a clinician, you think about trauma-informed care, you think about what are the things that I say, or how do I ensure that that I'm co-regulating with the people that I'm interacting with, or that I'm not saying things that trigger a trauma response. But I think there's this whole other component of trauma-informed care that we could incorporate into our thinking and our clinical work.
Absolutely. I 100% agree. I mean, I see a lot of kids that come in to see me, and I'm like, it's very clear that they want to be in the hospital rather than being at home. And a large part is because they're not having their basic needs met, like food, shelter, those basic things. But like, for both of you guys, like, how would you guys address this with a family? Because like, some families are very prideful and feel very offended even asking, hey, are you getting enough food at home? Like, so how would you guys address that with the family?
Yeah. So I think there are two things that I wanted to say, and there is a tool called the SEEK questionnaire, which was created by Howard Dubowitz from the University of Maryland, which was really designed for primary care settings, but probably could be applied to a few other settings. And it gives you a framework of asking those questions about kind of basic needs that might make things difficult. And, we just think of Maslow's hierarchy, and, I'm one who's quick to say, okay, well, this has happened to them, and I'm sure they would benefit from therapy. But, if you don't know where dinner is coming from, the idea of scheduling an appointment for therapy is real low on the totem pole. And so kind of, to Claire's point about, how we address and the importance of addressing basic needs, even though in the healthcare setting, we might not be the agency that's going to provide those resources, but we certainly can connect families to those entities that are able to support them. I do want to mention on the intervention side that our healthcare system, from a policy perspective, and which ties into a reimbursement perspective and an RVU perspective, doesn't support what we're talking about. It does not support a model of having the staff to do exactly what we're talking about. It supports a model of very quick visits and a whole bunch of them. And it doesn't necessarily even support having skilled professionals who are not MDs or nurses to work in partnership with the medical team to kind of actuate these things that we're describing. And so, I love to talk about what we do directly with patients, and I'm fortunate to work in a division where we do have someone who helps families and identifies those kind of challenges so that they can meet some of their basic needs as much as we're able to help and connect. But it's a struggle to support positions that are able to do just that, so that we can keep seeing patients.
I think that's why a few of the new Medicaid waivers related to the social determinants of health are so exciting, whereby there are reimbursements for navigation, for housing, for food, for utilities. with a growing understanding, even at the federal level, that if we are not taking on social determinants of health, we bear the brunt of those costs in the healthcare system and through society as a whole, in child welfare and the justice system. And so I have encouraged most states where I'm working to review the recent 1115 waivers, as they're referred to at the state level, particularly the ones that are oriented around social determinants of health. Oregon, California, North Carolina in particular, the fee schedule there is fascinating. And so, as you think about, and then there's also a program out of the Innovation Center at CMS, at HHS, the Integrated Care for Kids model, which is trying to avert deeper involvement with our public systems by addressing an integrated care model through the health platform. So there are these new innovations that are emerging. And so I think that those are incredibly important to not just advocate for within the district, for seeking a waiver like that, but also just understanding what those care models look like and what the likely implications are for them over the next 5 to 10 year horizon.
I have a question about those 1115 waivers. I've been involved in one of them, but how easy is it if you're like in private practice or something else to like maybe access that?
Yeah. I mean, those are any one practitioner is, I think, going to have a hard time accessing the power of those waivers. I think you really need a coordinated state approach. Even the states that have them don't have them universally. It's a target population or particular geographic area. But understanding what is in your 1115 waiver or what could be in it, and having one voice about what's necessary, I think could be really powerful.
So what I kind of hear you saying is like you probably need to form an advocacy kind of initiative in order to address this.
Never a bad idea.
Yeah. I mean, I guess that kind of leads into the next question then, like how can pediatricians and other medical professionals engage in advocacy to prevent and address these?
Yeah, I mean, I think this is exactly right. As an entity, associations at the district level, but also at the national level, I know the American Academy of Pediatrics is quite interested in early adversity and having a united voice around social determinants of health and what kids and families need. So I think just sort of first understanding what the literature and this new body of science says to us about what reduces, really prevents early adversity and adverse childhood experiences and social determinants of health. And leaning into those from an advocacy space, I think is important. When you're a clinician, when I was a clinician, I didn't always think about this higher level or ways in which I could put my voice with others. The other, I think, is to, when you are doing clinical work, is to understand that you're starting at chapter 14. Not that anyone who's listening to this webinar doesn't understand that, but knowing every time you're walking into a room that there's a context, not just for the family, but there's a policy context in which that family exists, in which we all exist. And ensuring that you're sensitive to that context and are looking for not just what's the thing that has shown up in my office today, and not just what are the adversities that have happened, but what are the ways in which I can connect families to resources and lean into the policies that are important and get them what they need.
That makes complete sense. I mean, we were talking earlier about stigma, and I thought what you said, Claire, was very fascinating. Can you explain why you don't like that? Like what you kind of explained to me earlier about not want to use that word.
Yeah, I tend to approach the concept of stigma as one in which I'm looking backwards and I might be inadvertently overlaying a cognitive narrative about what the family has experienced or is experiencing or might in the future. And I tend to try and orient around what are the big policy changes that can be made to improve the lives of families broadly, and this particular family in front of me as well. I think we just, maybe a better, more straightforward way of saying it is that I think we have a number of policy artifacts that we have floating around and are part of our consciousness or subconsciousness, and we don't even really realize it. And by bringing stigma forward, I think we might inadvertently reinforce stigma rather than looking for the way out that is oriented in resilience, that's oriented in solution finding with families and solution finding at the policy level. Now, whether or not that's always going to get us there, probably not. And certainly there are folks who are who feel very deeply stigmatized about lack of resources or the context in which they find themselves. But increasingly, I'm seeing across the country people feeling pretty empowered to focus in on the systemic inequities rather than an inward-facing stigma.
No, I think that's really, I like how you said systemic inequities, because like that is like essentially what a stigma is, in my feeling, is like systemic inequities. And I feel like we have to address that for sure, because otherwise people aren't seeking mental health. And even the word resilience, like if I fail, am I not resilient? And so I now have this, like, is that a problem? And so like we have to be careful with using these words as well, because
I agree.
we all break down at some point, and now we're failed. We didn't get the treatment. We're all these other aspects. And so I think choosing the words we use so it's not internalizing is very, very important. And it's hard for sure.
Really hard.
I don't know, Dr. Jackson, do you have any thoughts on what we were just talking about?
Yeah, I think we're speaking to kind of our attitudes and maybe preconceived notions or assumptions that we might make. And it's easy to do at the bedside. We are all subject to judging a book by its cover. Yet what we might convey is a lack of understanding of the context for a patient or family and their circumstances, even more so if we are different from them in some way. And so that can easily put us in a position of being an unsafe space. And so it's important, it's ironic that, in 2023, we're having these conversations about adverse childhood experiences. And, I finished my residency right around the time that the study was published in the late 1990s, and knew absolutely nothing of it at the end of my residency, and didn't begin to learn about it until I started working here in the Child and Adolescent Protection Center, which is the year 2000. And routinely would ask trainees who would be rotating here if they'd ever heard of it. Resounding no, over and over and over again. That has changed. And so, it leaves me hopeful in that my hope is that healthcare professionals understand more about the impact of traumatic experiences and what that might be like for survivors of those experiences, which gives us a context for how they may engage with us, their receptivity to our recommendations. When we talk about stigma, the word stigma, and what that might look like in a healthcare context. One of the main points of the ACE study was that trauma is common.
That's right.
And if it's common, then we really should get away with move away from the stigma. Odds are many people have experienced something, and we know kind of the concept of ACEs has expanded to include other things beyond those original adversities in childhood. And so, any one of us could check off at least two of those things if we, really took the time to reflect. But I think the point is that, look at how successful so many people are despite those circumstances. And, we can not only learn from, those who are struggling, but we can learn from those who have kind of overcome their adversity and have thrived despite the adversities that they experienced. And use that and integrate that understanding into our efforts at implementing policies in our workplaces, in our communities, in our nation, so that, I could be put out of a job here at the Child and Adolescent Protection Center, and we have a community that of people, citizenry that is thriving. Truth of the matter, it might put a lot of the healthcare professionals, not just those doing child abuse work, out of business. And so, we have to be ready for that outcome. But wow, what a world it would be if that were the case. And so, beyond those things that Claire, I just wanted to say, what can we do? And as a pediatrician, I'm so proud of pediatricians because I think we have been some of the most vocal advocates in healthcare for a long time at the legislative level. But, one of the easiest ways to be an advocate is to vote. And to ask your patients, are you registered to vote? Do you need help? Can I connect you with, how to get registered? I mean, I think there are a lot of ways, at the macro level, which is Claire's space, and at the bedside, which is, kind of my space, to be able to move the needle forward, so that, as many people as possible can be thriving moving forward.
I mean, absolutely. I mean, I 100% agree with that, and what you're saying. And pediatricians have been in the forefront of that. Like, they've have like all these papers on advocacy, and it's incorporated into your ACG requirements. And I'm wondering why, like, now at this point, why is the psychiatry not doing the same thing and making it part of your training requirements of learning how to do this and address these issues? Because psychiatry, in many ways, we address all of these issues that we're talking about even more often. Not saying pediatricians don't address it all the time, but like, this is like what I do every single day, every single patient. Let's address like ACEs, social determinants of health, because that is what's driving a lot of these issues. And I also agree with you, Dr. Jackson. I wish that we address these things, because I would be out of a job, and that would mean our healthcare system is doing amazing. And that would be a great wish for me. Well, we have a couple minutes left. Is there any last minute talking points that either of you want to bring up?
Just incredibly grateful for this opportunity to have a conversation with you all about such important policies and clinical practice. Dr. Jackson, as you noted, there's a lot to be optimistic about. The study, the adverse childhood experiences study, studies around social determinants of health, the studies around economic and concrete supports, and studies around relational health, I think give us a really nice blueprint or roadmap for the next decade, just like the ACEs study gave us for the last decade. So I'm looking forward to being part of that discussion, and far more importantly, for pediatricians and psychiatrists and the medical professional as a whole to be really deeply engaged.
Dr. Jackson, your last soundbite.
Yeah, I guess my last soundbite to complement what Claire shared, and I mean, I think the conversation is an illustration of kind of interdisciplinary collaboration for the betterment of everyone. And I would just, kind of add that it is truly important to lift up the voices of those with lived experiences, and that might not translate to a research paper, which is kind of a very Western approach to validating knowledge. And I think it's really important to uplift kind of the principle of storytelling. We learn, that's what we do when we get a history, right? We're hearing someone's story, and it is the guide to our plan, right? Most of the diagnosis is in the story, the history, not all of the objective findings that we uncover with our exam and studies. And so I think, in that same vein, at the larger level, being sure that we're incorporating the voices of those with lived experiences and valuing their voices at the same level that we're valuing kind of that clinical evidence-based research that is important without question, but not to the exclusion of the voices of those who have lived it.
Those are both excellent points. Thank you so much for joining us today. And I'm hoping that everyone that is viewing this webinar have found it as equally, I don't know, not entertaining, it's not the right word, informative, there we go, informative as I did.
Thank you for the opportunity.
Thank you.